Welcome everyone to the December 14th, 2020 COVID-19 clinical rounds, EMS on crisis care. My name is Richard Hunt. I'm an emergency physician who serves as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer real-time sharing of COVID-19 clinical challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration. Thanks to the multiple professional organizations who have collaborated on these rounds. These rounds are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC has webinars that complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Bruce Strebinger and his team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Tomorrow, Tuesday, December 15th, will be the 100th COVID-19 clinical rounds. A special session with our speakers from our early rounds back in March and April, providing their insights on what they've learned, current emergent needs, and what we'll need to focus on in December 2021. Then on Wednesday, we will have another one in the series of emerging therapies. That series of rounds began last week. And so Wednesdays will be those rounds. And then on Thursday, December 17th, we will have COVID-19 clinical rounds, emergency department innovative PPE strategies. Next week, EMS rounds will be on Monday, December 21st. Critical care rounds on December 22nd will be focused on pediatric ICU care of adults. Those December 22nd rounds will be the last rounds for 2020 in recognition of the holiday and in support of all clinicians fighting fatigue and in support of mental health of our clinicians. Stay tuned for updates on next year's rounds. Dr. Strebinger will now go over some logistics.
Thank you, Rick, and welcome to Donnie and Jeff from Colorado, who will be presenting today, our neighbors to the north. And welcome to our expert panelists and to the nearly 200 participants signed in. As Rick said, I'm just gonna go over a few logistic items. Reminder that we love getting your questions and comments, so please keep them coming. Put them in the Q&A feature along the bottom of the Zoom toolbar. There is a chat function. If you have technical or logistic questions or issues, please put those there. Also, Rick will be asking a crowdsourcing question, and please put your responses to that in the chat function. We are recording today's session as we always do, and your attendance is consent to be recorded, so thank you for that. Today's presentations should be linked to the most recent email announcement that came out this morning from Project ECHO. We will also be putting them on our ASPR Clinical Rounds website, and we'll share a link to that in the chat, and we'll have a link to the recording of today's session there within a few days. We are offering CME and continuing professional development credits through Project ECHO and the University of New Mexico, where we're based. There should be a link in today's email announcement to the CME survey. You have 48 hours to complete that. We'll also put it in the chat about 15 minutes before the end of today's session. We really appreciate the feedback you give us when you complete the CME survey, and hopefully the CE credits are useful to you as well. Just as a reminder, these learning sessions are focused on improving patient care and health systems and supporting clinicians. Let's keep them apolitical and non-commercial. Thank you for that. And just a word about data use. You share data with us when you register, when you answer the polling questions and enter questions in the chat. We just want to ensure everyone, we take data stewardship very seriously. The data we share with Rick and Asper is all de-identified. Most of it's de-identified up front, but what isn't, we de-identify before sharing it with Rick. Rick mentioned that the NETEC, National Emerging Special Pathogen Training and Education Center, is a partner in these clinical rounds, and that they have their own fabulous webinar series. This Wednesday, they're doing a webinar on responding to vaccine hesitancy and misinformation. And Friday, they're doing a webinar on alternative care sites. So we encourage you to check that out and their archive of recorded sessions. Also, just a reminder, we're supporting a mini series on outpatient therapeutics focused primarily on monoclonal antibody therapy, but hopefully will also include polyclonal antibodies and other outpatient therapeutics as they become available. The next session is actually this. The first session was last Wednesday. The second session will be this Wednesday, and it's at noon, and we'll put a link to register for that for anyone interested. Also, the Association of American Medical Colleges is a partner in these clinical rounds. They have a terrific clinical guidance repository for COVID-19. They keep it updated every week, and we recommend you check out that resource. With that, Rick, back to you for the crowdsourcing question.
Yeah, thanks, Bruce. As we have talked about on the rounds for months now, there are profound challenges in with clinicians and fatigue and complacency. We did this on Tuesday's rounds, this crowdsourced question, got a lot of novel answers, and I think it became its own sort of self-help group. So if you could please share with others what for you personally, what is currently effective in fighting clinician fatigue. And by clinicians, I absolutely mean EMS clinicians with this, as well as the others who are on these rounds. So please step up and help each other. And if you wouldn't mind responding to that question, I think we've all learned a lot through that. So with that, if I could ask each of our panelists to take themselves off mute, and I'll go around the Hollywood squares and ask each of you to please introduce yourselves. Carol.
Good morning. I'm Carol Cunningham. I'm an emergency physician. I am the State Medical Director for the Ohio Department of Public Safety, Division EMS.
Thanks. Dan Gerard.
Dan Gerard. I am the President-elect for the International Association of EMS Chiefs, and I'm also the EMS Coordinator for the City of Alameda Fire Department.
Thank you. Dave Gerstner.
David Gerstner. I'm with Dayton Fire Department in Ohio, and I'm the MMRS coordinator for the West Central Ohio region.
And Dr. Kramer.
I'm the director of the NHTSA Office of EMS and the team lead for the HHS Healthcare Resiliency Working Group EMS Pre-Hospital Team.
Thanks, John. Doug Kupas.
Hi, Doug Kupas. I'm an EMS and emergency physician with Geisinger Health System in Central Pennsylvania. I'm a EMS medical director and director of our MIH program. And I also serve as the state EMS medical director for Pennsylvania.
Thanks, Doug. Rob McClintock.
Hi, Rob McClintock. I'm the Deputy Director of Fire and EMS Operations with the International Association of Firefighters.
Thanks. Alex.
Hi all, I'm Alex Isakov. I'm an emergency medicine and EMS physician at Emory University and the EMS lead for NETEC.
Great, thanks Alex. Dave Gerstner and then Mike Levy. Dave. That's David Gerstner. He may have had to step away.
Yeah,
Mike.
you got David already.
All right, Mike.
Hi, Mike Levy. I'm the President-elect, the National Association of EMS Physicians, State of Alaska EMS Medical Director, EMS Medical Director for other agencies here in the state. Thanks.
Thanks, Mike. So with that, welcome panelists and welcome especially to our speakers from Colorado, a great state of Colorado. Donnie Woodyard is the branch chief for emergency medical and trauma services at the Health Facilities and Emergency Medical Services Division in the Colorado Department of Public Health and Environment. Dr. Jeff Beckman will join him. Jeff is the Medical Associate Division Director for Health Facilities and Emergency Medical Services Division, again, for the Colorado Department of Public Health and Environment. With that, I'm going to turn it over to the two of you, please.
Thank you so much, Dr. Hunt. It's an honor to be here. So during the next few minutes, we want to talk a little bit about the EMS crisis standards of care and kind of the pathway that Colorado took to develop and implement these standards, and also a little bit about the PPE crisis standards of care. Okay, apologies for that. So a little bit about the Colorado EMS and Trauma System, just as a way of background that kind of adds some context to the crisis standards of care that was developed here. Colorado has a population of just under 6 million people. And when you look at the distribution in Colorado, we have 64 counties. And out of those 64 counties, 8 would be considered to be urban or suburban counties. The rest are rural or frontier, with the majority of our counties being classified as frontier. Our EMS services respond to about 750,000 incidents every year, and this is in normal pre-COVID times. And we have about 485,000 transports out of that 750,000. The split in a normal pre-COVID time is about 25% is trauma, 75% is medical. The services in Colorado are provided by about 200 licensed ambulance services with about 19,000 EMS providers. We have 84 designated trauma centers, and that would include everything from a level 1 down to a level 4. We do have a couple level 5 serving our ski areas, and we do have a non-designated criteria here in Colorado. In addition to our ground services, we have 30 licensed and recognized air ambulance agencies. So this is the beginning context of us developing the crisis standards of care. Real briefly, the Health Facilities and Emergency Medical Branch is part of the Colorado Department of Public Health and Environment. And if you look at this chart, you'll see that our primary branch is under the Chief Medical Officer, Dr. France. With that, I'm actually going to introduce Dr. Jeff Beckman, who serves as our Assistant Division Director and our State Medical Director, to talk a little bit about how the crisis standards were developed and the process of implementing them. Dr. Beckman?
Thank you, Donnie, and thank you everyone for the opportunity to be here. I'll refer to the Colorado Department of Public Health and Environment as CDPHE for efficiency and not having to say that every time, so just for reference. But our department is, again, both public health and also environment. On the left side, we have the public health, and the right side, we have environment. And then our executive director is Jill Hunsaker Ryan. The two branches that are really brought together to really look at disaster preparedness and planning is going to be within our health facilities and EMS branch, who our director is Randy Kirkendall, and then lower down our disease control and public health responsiveness, otherwise called Decipher, Director Scott Bookman. I can say that we have, of these leadership positions, we have Mike Nugent, Randy Kirkendall, and Scott Bookman, who are all paramedics. So very atypical, I think, in a public health department to have such EMS leadership, but we're really fortunate to have their lead in many of the things that we do on a day-to-day basis. So just to give some context on how we got to our disaster preparedness plan. So for many of you can remember the exercise Top Off the Top US officials, which was a national $300 million drill funded federally to assess our nation's capacity to respond to a crisis. Denver was selected as one of 3 US cities, and Denver got the drill for a bioweapons attack from the release of the aerosol Yersinia, so the plague. The other 2 cities were Portsmouth, which was a chemical weapons event, and then in DC, a radiological event. And with this, it was very clear that as we planned for this in Denver, that we really didn't have a great mechanism to develop a statewide disaster preparedness plan. And thus a statute came through legislation, and this was created in 2000 as a result of this drill. As far as the activation, the governor or the CMO of CDPHE or executive director can convene the GEERC to meet, and the GEERC was created out of this group to plan, and this is the governor's expert emergency epidemic response committee. And next slide, as you can see, the membership is fairly extensive. We've got 19 members, and these are also inclusive of 3 ex officio and functional backups. And this is anywhere from ethicists to CDPHE to emergency managers to really encompass all aspects of the community. And guidance in this was in 2008, just before a fortuitous H1N1 swine flu pandemic, which really brought the plan to really more focus on pandemic type events. Next slide, please. So in the plan itself, really relied on the Institute of Medicine's Crisis Standards of Care, the system framework for catastrophic disaster response. And this was the roadmap and ethical guidelines to really create this plan. And so one of the founding principles with this is that duty to plan. So in an important ethical sense, entering a crisis standard of care mode is not optional. It's a forced choice based on the emerging situation, and under the circumstances, failing to make substantive adjustments to care operations, i.e. not adopting a crisis standards of care, is very likely to result in greater death, injury, or illness. So it really is imperative for each state to develop these as part of its preparedness and response. And additionally, this is declared by a state government and recognition that the crisis operations will be in effect for a sustained period. This isn't just a one and done. This is something that's going to be in place for quite a long period of time. And as part of this, it's really imperative that there is a specific legal regulatory powers and protections for the healthcare providers. You know, understanding that providers are faced with a scarcity of resources, a scarcity of equipment, space, and all of these things considerations, that doing the greatest good for the greatest amount of people, there should be legal protections in place. And that's one of the real integral parts of this plan that has been developed. And with the recommendations, this is again in development of the plan, really some of the founding principles. And in addition to this, there's really 4 main ethical principles that kind of led to these 5 that essentially led to the founding of this document. And the first is fairness. This should be fairness to everyone in the community and have no regard to specific factors such as race, ethnicity, socioeconomic status, disability, and then especially for Colorado, the region. So we want to make sure our rural areas have the same level of care than our urban centers with all the resources. The second thing is that the response should be proportional to the degree of the crisis or emergency. And there needs to be solidarity with consideration that the entire community is rallied behind the greatest good for everyone. And then in this process, it needs to be participatory. So community, the healthcare systems, emergency management structures, all need to be engaged and in place for really this to be a widespread, well-adopted document. Next slide. So with all these in place, with the COVID-19 specific response, the GEERC did meet on February 13th and really felt that there were some revisions that needed to be in the planning document specific to COVID. And with this, they convened a subject matter expert group. And this was actually very fortuitous because at the same time, the Colorado Healthcare Ethics Resource Group was already looking at adding in some of these ethical principles and guidelines. Next slide, please. So this group was about 30 members, and again, very multidisciplinary, including community members, ethicists, emergency management, and clinicians. And the real focus for the COVID response was really broken down into three main categories: the hospitals, EMS, and PPE. And expanded also to include palliative care, behavioral health, and then a community engagement group was also mobilized as part of this process. And this was implemented fairly rapidly. So on April 5th, the plans that were put into place, so the hospitals, EMS, and PPE, and of those, the EMS and PPE plans were activated on April 7th and April 8th. And this was approved by our chief medical officer and forwarded to the governor. And with this, for EMS specifically, the main thing I think many folks had questions and initial problems with is they felt it was a all or none document. And the main thing is that with this, there is a fluidity of the initial call from dispatch to the operations from the agency and providers to the medical care, and then also transport. And it's important that for that proportionality, that there need to be components activated within that plan that is really specific to the needs. So it's not an all or none. It's felt that the agencies must adopt the components of that that are really pertinent and proportional to the resource scarcity or the crisis that's ongoing in their community. Next slide. And with this, this is the breakdown that we had for EMS, starting with the PSAP, going to modified call queries, then potentially to the point of crisis, where there is either a non-response and triage to a nurse line or a very delayed response. From the EMS agency standpoint, is also looking at only one licensed or certified EMS provider, a non-medical provider. And then some of the medical aspects, we're looking at CPR specifically, that would not be performed unless there was PPE in place. And then also patients in the crisis component of the plan should not be transported unless there's return to spontaneous circulation. One additional component was added at the end was the problem of potential widespread hospital divert. So there was a development of a rotation for low acuity patients with the hospitals in that aspect if everyone was on divert and with difficulty receiving patients. The bottom line really, if that fails, is that if everyone's on divert, then no one's on divert. And essentially those things were written into place to ensure that patients can be not only load balanced, but also if a time-dependent condition exists, that they get to the closest facility, the closest period of time in order for those real time-dependent conditions. And at this point, I'll turn it back to Donnie.
My apologies there. It would not let me unmute and share the desktop. So with the plan being implemented, this is a look at currently right now. So currently across the state of Colorado, you can see that 46 of the 64 counties in Colorado have adopted the EMS crisis standards of care. Now, part of the adoption process was for agencies to actually adopt. They have to create their own triggers, their own action matrix, and then report back to the department utilizing a Google form. And we've had over 200 entities adopt the crisis standards of care. And interesting enough, you can see that across Colorado, the far majority of our counties have actually adopted and implemented parts of this crisis standards of care for EMS. It's important to note that this is a reflection of the EMS crisis standards of care. It's not reflective of the PPE crisis standards of care, which is even more widely adopted across Colorado. So with that, we'd like to open it up for any questions about the EMS crisis standards of care. And in this document and the meeting materials, there's a link that you can actually download the crisis standards of care documentation. So with that, Dr. Hunt and panel, thank you for the opportunity. We're happy to take any questions.
Yeah, Donnie and Jeff, really appreciate this presentation. It's actually the first one we've had on crisis care specific to EMS, and it was a great overview with some real specificity to the EMS issues, challenges, and how you move forward with it. I have one question, then I'm going to turn it over to the panel. Okay, so in offices, in agencies, leadership across your state, working through this, how are EMTs, paramedics being educated? How is this information being shared? And their input, reactivity to it, or total acceptance, thank goodness it came. Some input on that I think would be helpful to share.
Thank you. I think I just want to go back to the point. I think the biggest initial hurdle was just that it isn't an all or none document. Really, there's just certain components, and then where you are in that conventional to contingency to crisis phase really depends on what aspects that you would implement. And it's going to look differently. It's going to look differently based on your resources. There may not be much components of the PPE plan if you've got a lot of equipment, although there may be certainly some staffing issues where you need to think about how can we look at modified call queries or other triage mechanisms, or even potentially non-transport, which was also in the document. So I think that was the first thing. Otherwise, we do have a state Google Drive that has all the documents, including our COVID guidance for EMS, our exposure guidance, also some training on swab testing, which was one expansion of scope that we did to help with the response. So it's all in one place. And then additionally, there was some reach out to our regional medical directors and local medical directors to help with the education down to the crew level. But really, I think, overall, it was a relief to have everything in this document when we were, advising to do IM epinephrine as opposed to nebulization for the concern of aerosol generated procedures. It was nice to have that somewhere in writing to give, really empower our clinicians in the field to be able to make those tough decisions or those, potential perceived alterations of care.
Yeah, Jeff, I was particularly struck by your comment through the presentation about it's not an all or none phenomenon. And I think, the reason it really hit home was thinking about the presentation we had on session we had on Thursday from Dr. Jeff Dichter on Minnesota's crisis care plan. And he showed a chart or graph that showed the up and down surges and how, turning it on off, you actually had to track with the reality rather than, like an executive decision, we're turning this on, and then everybody kind of like stands back and waits until somebody turns it back off again. That there's some slow motion effect in terms of like, well, it's getting better. Are we really in it or are we not in it? And that sort of like gray zone makes it really hard when particularly EMS providers like some clarity for sure. So, and also I was struck by the sort of like individual county by county, them tackling it head on rather than the state deciding we're all on all at the same time versus not all on. I mean, I really appreciate that sort of like the waxing, waning understanding that it's not going to be the same everywhere. So that was really insightful. How about to our panelists? Questions? Yes. Thank you, Dan. Especially appreciate you raising your hand. So I could, yeah.
Not to worry. I have two questions, and actually, the first one is for you, Rick. The national level exercise that's generally run, which I believe the Colorado kind of reference that they did in 2000, has any of those ever focused on an extended duration event that has gone on for months? And then my question for Dr. Beckham, thank you, sir. Beckman, thank you, sir. A great presentation. The transition from conventional to contingency to crisis standards of care. It almost seems the way you described it, you didn't, I don't think I heard you say anything about a time frame. Like, how quick was that transition from contingency to crisis? Or did you find yourself that, you went immediately from conventional standard of care right to crisis? And again, great job. Thank you, sir.
Right. And I think this was very regional dependent, and actually the first part of our response, the hardest hit areas were the ski areas, because that's where we had visitors come in, and we saw really the hospital capacities being exceeded in the mountain areas first, which was pretty interesting for us. And so that was a situation where they're in conventional, and then they went right to crisis, because already within weeks of in that first part of the phase, their ICUs, their hospitals were at capacity, their call volumes were at capacity. And then in other areas, it's been kind of an ebb and flow. You're kind of going between that conventional to contingency to crisis. And really, I think, the way that the document was built was meant to be fluid. And the fluidity is that you're starting in more of a kind of a conventional contingency phase. And then there's some additional components to implement, such as non-transport, a potential modified call query from dispatch, or even some parameters for cardiac arrest. So I think that's really, and then those were really time dependent based on the system. So what we saw specifically to non-transport, there were some agencies that enacted that after the plan, so in May. And then by the time that June rolled around, we started to see the back end of that surge, and then they discontinued that aspect, but continued in the plan. So that's, I think, one thing to know, that in those different components, it is really imperative to have a time to start and a time to stop with.
Yeah, Carol.
Yeah, thanks for a great
Carol,
presentation.
hang on for just a second. Hang on for this second. Dan, I want your first question about, you were asking about, like, did agencies do a long-term kind of event kind of thing? And yes, we did about a year ago, and it was red something, and I can't even remember the name of it, but it was long. It was very long. Yeah.
Thank you, Rick.
Yeah, I'm sorry, Carol. Sorry to interrupt you.
Great presentations. One of the challenges we have with crisis standards of care is engagement of the community, the actual clients that we serve. I know it's easy to do with stakeholders, but I was just wondering what avenues, if any, that you took with communicating the changes as you went from contingency to crisis with the community, particularly in an environment where normally you do it like at a town hall meeting. I don't know if you went on TV or had, flyers put out, or public information on announcements on TVs, et cetera.
Thanks, Carol. The initial media coverage was actually statewide from our chief medical officer that introduced the plan. And then for the kind of the local counties were at either local district boards or, county commissioner meetings virtually. And I think that's been the one benefit of being virtual. It made it real easy to be able to navigate a lot of these different meetings and present that. But I think, in Colorado, as being a home rule, local controlled state, it was important to engage the county commissioners, some of the local city and district boards, just to give communication in that forum that has public and also local government about what we're doing, the reasons behind it, and get community feedback.
And how did you handle any negative feedback that you may have gotten from the community members? And by community, I mean, the general public.
Yeah, I think interestingly, the one component that was probably the toughest that never got activated, as knocking on wood as of yet, was the hospital plan, because in the hospital plan, they covered the structure of how to allocate ventilators. And I think that got the most concern publicly is, well, if I'm in an ICU and we're running out of ventilators or beds, how is that going to be allocated? So there was, certainly some public discussion on that, where, as far as how that worked is a hospital crisis triage team is developed. They do a score based on the acuity and then longevity of what the expected life is going to be, and then break that down to different tiers. If there's a tie, then looking at pediatrics or healthcare workers, and then ultimately down to a lottery. So there was a lot of work with our ethicists, and I think that probably had most people concerned is how that would be, because there was so much attention about the lack of ventilators and ICU capability. Fortunately, that hospital plan has not yet been enacted in Colorado.
Thank you.
And real quick, I wanted to circle back to part of Dan's question on, the implementation in the community. Understanding that much of our state is rural, part of this crisis plan actually even addressed down to how these rural agencies, largely with volunteers, largely with aging volunteers, are impacted. And one of the components of the plan actually allows the changing of staffing of an ambulance from 2 licensed or certified providers to 1 licensed and 1 unlicensed driver if needed. And so that's just another example of how this plan can be activated in the rural areas, where it's not necessarily, going to be the same in the urban and suburban areas. So I didn't want to miss that option on, just the importance of the rollout of this that kind of took into account the whole facet of care in multiple stages, not just the overwhelming of the statewide system, but if you have a small community with 5 responders and a few of them have COVID, how do you respond to that?
Yeah, Mike.
Great presentation. I really appreciate it. This question gets a little bit in the weeds, but just wonder if you can help me with it. And it has to do with the PSAP response. And as we dial that up to ultimately a non-response, one thing we've wrestled with in my neck of the woods has been maybe the happy hypoxemic, the person we've interviewed, even maybe by video, but without some type of objective measure or having somebody that can go in and see them. How can we be sure that these folks are going to do okay? Is there follow-up built into it, or just curious? Thanks.
No, thanks, Mike. There weren't really too many centers that actually implemented that component. And for that would be a nurse triage line where they essentially were deferred to in one system that had this in place for about a month. And with that follow-up, there was essentially just an outreach to a call line to their primary care health system. But again, used very rarely from the dispatch side. Some other programs with dispatch had kind of a modified response with a telehealth provider where a link would go and they would actually engage from the call to either a community paramedic or a physician and have a telehealth encounter, which gave a little bit higher level. But I think your point about, well, the one thing that certainly had us all concerned is, well, without vital signs, how do we know they're not hypoxic? And what components where we can get from that hands-on to the telehealth. And so as part of our non-transport, really for that piece of the protocol, that we did have a provider-based and vital sign criteria in addition to high-risk criteria. So that's a hands-on component. But as far as the triage lines, those were the 2 programs that we've heard in place, but very time limited. And those were systems that were truly breaking at the seams.
Doug, yes, please.
So one of the things that intrigues me about, and first of all, thanks Donnie and Jeff for doing this topic. It really is an important one, I think. One of the things that I find interesting is I think this is, like everything in medicine, a bit of a spectrum where, some of the things you described, like not transporting patients that don't get ROSC after CPR, in many places you could suggest that is the standard of care. or an alternative to a nebulizer by giving the medicine IM. To me, those are sort of a little bit on the, well, is that big a deal? But then on the far end of it, that's what intrigues me the most. And Mike brought up the 911 centers, and I wonder how you have handled in your plan the idea, just like ventilators in the hospital, if you don't get the ventilator, you don't get the ventilator, and that could be a big issue. If 911 decides we are not sending an ambulance, or we're going to send you to the nurse advice line, does your plan allow patients to say, well, the nurse advice line information, that was nice, but I want an ambulance, I want to go to the hospital. If they call, are you going to send one? Same with some of these plans to do treat at home. We're doing and have had a protocol for treat at home with a checklist, and it's been used throughout parts of the state. But it still allows the patient, if they don't agree to the treatment at home, to be transported. So do you allow any forced, no, you don't meet these criteria, we are not transporting you no matter how much you want to go, or no, we're not even sending anybody from this 911 call because you don't meet these criteria? Does your plan get to that point if there was such a surge?
Thanks, Doug. I think that's important. In the plan itself, there is a component of patient consent, and especially for the non-transport piece, is that, if the patient's unwilling, then, we have to think of another alternative. So that consent, I think, is really important, and knowing that the patients are on board with this process and understand why, those programs are in place.
Yeah, I see that as one of the big differences between or similarities to when you get to the ventilator discussion in the hospital, because you get it or you don't, and even if you don't agree with it, there might not be one there for you. Same could apply in a real surge. I also wonder about the people that have Samsung phones that are newer really have a pulse ox. I haven't heard anybody incorporating the fact that many of the people's smartphones have pulse oxes.
Yeah, that's the first time I actually heard somebody mention that. I mean, on these rounds anyway. Alex, you look like you had a thought.
Yeah, thanks, Rick. Donnie and Jeff, thanks for a great presentation. A little bit different way to look at contingency and crisis standards than we've been talking about thus far. Thus far, we've talked about how we're curtailing, because we need to, services to our community. But often, if you'll go into the CDC website and you see contingency and crisis standards as it relates to even equipment that we need to run the next call, right, with modicums of safety. So contingency standards on how to use PPE, or crisis standards given shortages, supply chain interruption, reuse and extended use. Is that addressed also in this statewide plan?
It is. It's touched on fairly briefly in the EMS plan, but there's also a specific PPE plan. And with that plan, that could be adopted by EMS agencies or facilities. So it's a little bit more widespread and really details to all those different components that you just mentioned there.
Thanks, very helpful.
John, then I have one question from our participant, then we'll go to the polling. Yeah, John.
Thanks. Thank you both, Jeff and Donnie. I'm not sure if this is an academic question or rhetorical. In your discussions with folks, is there a distinction between what is a contingency component and what is a crisis level component? And if so, is that standardized across the state, or is there variations among the system? Would one system view their system to be in a crisis level and another would just view that as contingency?
Now, John, I think that's a great question. And again, that's really left to the discretion of the counties about what components really fit. I think the couple things that really were deemed in the crisis was if there was a non-transport, if there was a referral to a nurse line or a non-response from a 911, those were really felt to be really exclusively in that category. So those, and so we made, a real, document to really reflect it and really respect all the local needs. And so we didn't want to necessarily put specific things in each category, again, knowing that different parts of the plan might be in crisis, might be in contingency, and might be in conventional in the same system based on the staffing, the vehicles, and then the resources that are available to that system.
And I just shared a slide. We actually hid it from the presentation just in the interest of time. But as each individual agency adopts the plan, this is the template that they were given where they can work through some of these questions on that local level.
Hey, Donnie, thanks for sharing that. I mean, it's like definitely the IOM piece. I comment on John's question, actually. And his remark about, academic exercise piece. These, even Donnie, the lines, and I know you took the, this grid or adapted it from National Academies of Medicine. Well, let's see, National Academies of Engineering, whatever, in medicine, the National Academies. So I think one of the challenges that, as I've listened to presenters and some of the issues over a lot of discussion since March, is, conventional contingency crisis, they are indeed important academic constructs, but there's a slippery slope, that waxing, waning. And one of the things that was, I think Dr. Dichter commented on Thursday was, this is a real slippery slope, and you can end up on one of those blocks pretty easily. And you almost, it's like, you almost don't even know what's happening because you're in the middle of it. And he mentioned, I think he was absolutely right on. You got to get some people around you to think this through as you're like moving through it really quickly, because crisis care can happen with or without standards very, very quickly. And the importance of recognizing when you're getting a little bit beyond where you usually are in your care of patients, and making sure that there is engagement far beyond an edict from any agency or whatever, because it can happen really quickly right now. I mean, you think about the numbers that we're faced with right now, it can happen really fast, and you might not even, you don't even realize it. And you got to do some like checks and monitors of each other. If you're getting way beyond where you usually are, then what? And really getting people to not just talk, but really try to figure out what's going to be in the best interest of the greater good. So anyway, it's an observation from listening to a lot of people on the rounds. I'm going to go, there was one question, and then I got to go to the polling, and this is from a participant. I'm curious, and this for Danny and Jeff, I'm curious how we are addressing the application of standards without holding a person's disability status against them, as it is so intimately related to comorbidities, parentheses for the pandemic for sure. Are there rehabilitation specialists on the panel to help conceptualize the rehab potential of people if we have to make more decisions for allocation of resources?
No, I think that's a hugely important question, and and looking at elders and pediatrics and all of those special needs populations. And so with that, that was really what was the impetus behind that really broad stakeholders in that group. And I don't know, Donnie, if you have the slide, but essentially we've got a list of what all those folks were, just as far as a breakdown of the different folks that were involved in this.
Thanks for pulling that up so quick. Really appreciate it. And, in these crisis care discussions, increasingly the topic of not just the equities of care, greatest good for the greater number, but those populations that are most vulnerable right now. And it's pretty complex for sure. really appreciate your putting that up there. And
You know, and I will note that this slide
Yes.
is the makeup of the GEERC. And then under the GEERC, there was another committee, an SME committee of about 30 additional SMEs that focus just on COVID. And I don't think I have a list of the actual breakdown of that committee.
well, thanks for sharing that with everybody. Most appreciated. If we could go to the polls, please. And I know that right now there are like 240 people on. If you can hang on for the polls, there's about 8 questions. They usually take about a minute apiece, but I think they will be really helpful in informing everyone. And also, as we get the polls up, go ahead, Echo, and put the poll up. Thanks for everybody with their responses to the fatigue question. I like that one about avoiding the daily depressing networks newscast. That's one of my favorites, actually. Thank you. It's a personal favorite. I'm not going to read all these, except for there's one caveat for these today. Okay, they're for EMS providers or leaders to respond, so we can get some sort of like laser focused on EMS with these responses. Okay. All right, let's stop there. We've got 43% voted. Results speak for themselves. All right, next. Okay, my awareness or knowledge about crisis standards of care is sufficient for my being able to implement the principles of standards of care if needed. Donnie and Jeff, really appreciate your talking about like those ethical constructs and so forth, so on. That was really helpful. At 44% of voted. I'm going to keep it up for a few more seconds. And also, I've said it many times before, but really these results, we don't drill down to the individual's responses, like identify who responded how. So they're aggregated. Most of the crisis care questions were the same ones that we did on Thursday, only these are just exclusively for EMS providers or leaders to respond to. All right, 48% have voted, not bad. Let's go ahead and see those. I'll let you take a look. All right, next, please. I am confident that my organization will support me if I implement crisis care. Boy, people are jumping on this one quickly. Wow. Really appreciate the rapid responses. It really helps keep us moving along. Another 5 seconds and we'll stop. 47% have voted so far. All right, let's stop there. 48% of you voted. 95 of you voted. All right, let's go to the next question. This is select all that apply, okay? So for you personally, and again, EMS providers are leaders, which of the following have been the most useful and trusted sources of information about crisis standards of care? There we go, 50%. Let's stop there. It looks as if state or local health department is the most frequent response. Then HHS CDC, the second most frequent response. Also, Bruce, I think this was similar to what we saw on Thursday, but there were a lot of responses to my EMS organization last Thursday as well. Next. And I think the next two, I believe, are vaccine related. This is pretty straightforward. The next one, I really hope people can hang on to get the next one. %53% have voted. I'm going to leave it up for another 10 seconds, and then we'll do there's one last one. Just if those of you doing like a phone call or a computer, doing your email, you need to like bring it back for this last question because it's kind of like a deep dive and it's going to require a little bit more attention than the other ones. Okay. All right, let's stop there. 56% of you voted, 101 of you voted. And the results speak for themselves. We'll leave it up for a minute so people can take a look. All right, let's stop there and go to the last question. And the last question is related to, well, I'll read it. The most important reason I won't get the vaccine or I'm not sure I'll get the vaccine is, and then at the very bottom, because more of you are going to get the vaccine than not, there's like a not applicable. Okay. I'm getting the vaccine when available and offered. Okay. So there's like, yeah, I need to go to the board exam writing. Yeah, in service on that. But yeah, see what happens here. %51% of you voted already. Really appreciate people jumping on this. It's great. It's the last one. %57% have voted. See if we can get the couple more up. And then when after I show this, I'll go around to the panelists that are still available, and we'll go for last comment, and then Donnie and Jeff, last comments from you. All right, let's stop there. And show the results. It's very, very informative. Very much appreciate everybody's responses to that. There's some chat about the great presentation we had last week on the vaccine and how that might have actually biased this in a positive direction. At any rate, thanks very much, everyone. And let me go to the panelists. And let's see, Doug.
Yeah, I just want to say thanks to all. This was a fascinating conversation, both from the presenters and the other discussions. My interest at the end here has switched a little to the vaccine, because I do think we have to just turn our attention to exactly how we're going to get information to people about this, but EMS providers in particular for this group.
Yeah, Doug, I'm struggling right with you. We're at the worst point in the worst catastrophe, and there's a vaccine. And that's a lot of work. Dan.
Great presentation by both Donnie and Jeff. I would say that as providers, never again am I ever going to look at the national level exercise or Event 201 as something that's beyond my scope or something that I shouldn't be participating in. There's a lot of lessons to learn here, and as we're able to reel everything back, we need to do a better job for the next pandemic, because we had SARS, we had H1N1, we had Ebola, and those were all warning signs that something big was coming, and it did. Thank you again.
Thanks, Dan. Mike.
Oh, great presentation. Really nothing more to add. Just hoping our folks will go out and get vaccinated, and the vaccine will be available to all. Thanks.
Thanks, Mike. Alex.
Yeah, great presentation, guys. Really important topic. We're stuck in that vaccine question. I'm encouraged, I'll tell you, a few weeks ago when this same question was asked, it was about a quarter or a third of the audience that said they'd be willing to get vaccinated. And today it went up to 75%. We're doing something right. If it was the presentation last week that biased towards the positive, let's get that disseminated. Really important and valuable.
So Alex, what I'm hearing both from you and Doug is like, we're all for the bias right now.
Yeah, I'll roll up my sleeve and get the vaccine if I think it'll get, others in my EMS, other of my EMS colleagues to get vaccinated too.
And I will tell you, since last week, I actually gave at our weekly COVID meeting for all of our EMS providers, Ken's presentation, and with full honors to him for putting it together. And afterwards, I got lots of feedback from people saying, I was really skeptical about this, but this has really opened my eyes to what's gone into making this vaccine, and I feel comfortable getting it now. So I think we just have to get that out there.
And Doug, okay, so we got the rounds, got it, all right. But much like has occurred with some other things that have happened, like the PPE, the PPE, the staff shortage. It's like afterburners on steroids by all entities. It's not just the rounds, it's just like you just did with your organization, it's everyone. This is, the all hands is way beyond all hands. Getting those messages out is just like really important. And these rounds will not do it alone. And everybody knows that, but everybody doing this is going to be really important. Carol?
Again, great presentations. I think when people, even though crisis standards of care were written 10 years ago, people still think it's a national and a local and state initiative. even local systems individually should have their own crisis standard of care plan based on their resources. Certainly it's the states that really can facilitate that liability piece that's so important, making sure you have those protections. Yeah, I agree with what everybody said about the vaccination programs. Again, we have to get the community engaged, but not in the way that we do from a medical standpoint. The way I'm telling people is encouraging people to get a vaccine. First of all, EMS providers are in that top tier, so take that opportunity because that it is a scarce resource right now relative to the whole general population. But when it runs out to the community, they don't understand, well, they understand, but they're kind of tired of hearing about stopping the pandemic. My message is get a vaccine so you can take your kid on vacation and go to a baseball game this summer. Take a vaccine so we can get back to the beach and go to live shows. Take the vaccine so we can get back on a plane. And it's a whole lot cheaper to get the vaccine than to pay whatever fee the airlines are going to charge for you to get a swab up your nose every single flight. Get the vaccine and it's like your passport. Thank you.
Thanks, Carol. My 93-year-old mother FaceTimed me, and it's the first time in like, I can't even remember. She FaceTimed me and wanted to know if she should get the vaccine. And I said, well, okay, so Mom, at 93, there's like any number of ways you could die. And so let's see, on balance, die from the vaccine versus die from the virus. What do you think? And it was the end of the conversation. So yeah, anyway, she wants to like have a Christmas again too, or whatever holiday you celebrate. So with that, Donnie, where are you? There you are. Okay, couldn't find you. Okay, yes, last word from you and then Jeff.
Hey, well, thank you so much again. Really do appreciate the invitation to share. I think, a couple of the takeaways as we're reflecting on this, and that is developing and implementing this plan was built upon a strong foundation, a foundation of partnerships, both with agencies and community, between state, between region, and development of that partnership is essential, not only for this pandemic, but as we move into the future. So I think I would encourage everyone who's listening, if you don't have those strong relations in your community and with your state and with your local agencies, start investing in those today. And then the second takeaway is there's not truly a one size fit all as we hear from this. The needs in the rural and frontier are vastly different than that of in our urban and suburban areas. And keep that in mind as these plans are developed and implemented and reviewed. But thank you again for this opportunity.
Thanks, Donnie. Jeff?
Of course, just would like to echo everything Donnie said. I think the one thing in looking at these plans, which I think is going to be the larger response, is the recovery. And I think that's something where I wish I would have had a lot more information and a lot more, components and really addressing how this recovery is going to be from this pandemic response. And I think that's going to be something critical in the next coming year that we really assist our providers and our systems with.
So Jeff, thanks very much. That was like a perfect lead into tomorrow. You're going to hear from our first presenters from rounds back in March and April about what they see the issues are going to be in December 2021. So a reminder, the 100th rounds tomorrow. Also Dr. Struminger reminded us all the COCA call, what every clinician should know about COVID-19 vaccine safety started about 10 minutes ago. They're all archived too, but plus, actually I think CDCs might have longer introductions than ours. So with that, I think it's time to sign off. Thanks to our participants. Great. I mean, Doug, I got to tell you, I was stunned by those results in the polls too. I think you're right. I think, a month ago, the polls, wow, not nearly what they are today. So to me, that's a good news story. It's nice to end on a good news story. So thanks to our panelists, Echo, thanks. And Jeff and Donnie, just extraordinary. Really, not just insightful, but your willingness to kind of like really open up about the goods, bads, and uglies of trying to do this. Much appreciated. So hopefully see you all tomorrow for the 100th. Bye.